Thank you, Beth, and welcome everybody for this talk on AI. So if you go everywhere, it's all about artificial intelligence taking over a human brain. But I can tell you the disclosure here, this talk was made using my brain. So let's go on artificial intelligence, cardiology, cath lab. So every time you have to know, what is artificial intelligence. So let me give you a little bit of history. So artificial intelligence was there way back since 1950s. The term was coined then and in 1956. So if you see that early in the 60s, even for the students, there was some kind of a AI program, high school level algebra could have been done there. And subsequently, you can see that antibiotic treatment could have been given using AI technology in the 70s. But I think it's in the late 80s and 90s where it became a billion-dollar industry and it really has mushroomed. And it has coming down to a lot of things. And I'm going to go over what happened in the 2000 when COVID actually came. RNA sequencing prediction and everything was done using the RNA. So using artificial intelligence. So what is artificial intelligence? So it is just a big umbrella talking about what the computer can do exactly like what a human brain can do. So under that comes some machine learning where you train, you're giving certain algorithm to this computer, and once it is trained, it remembers that and it will keep repeating the same thing. So deep learning also is a part of a subset of machine learning where neural network, human brain is made of a lot of networks, and that network is the same thing being used and deep learning is being done. So there are a lot of these are interchangeable. Some people will use various kind of terms, but they all mean the same. So this is where artificial intelligence is one umbrella. Now you can hear about various things, and we are using artificial intelligence in a lot of our day-to-day activities. So if you know the language processing, everybody knows how to use Siri, fraud protection, they tell you make sure you're a human, not a robot. ChatGPT, everybody knows about. Then, of course, we have robots, and more important is face recognition, which is there on most of our iPhones. So what in our lives have we been using AI for? So if you see there, Face ID, which I already spoke to you about, and how infrared dots are used and then happens. Then Google uses AI to make sure that you are not a robot, a human. They'll check on that. So if you see there, in most places, there's no humans anymore. It's a bot that's talking to you, especially when you want to change your flight tickets and all that. It's a bot that keeps talking. You try to get a human, you'll never happen. And then what happened also was that one thing very important I will talk about is hallucination. And then if you see here, Waze, Google Map, what does it use? It's been using AI. So it has been there in our day-to-day life. Has AI been adopted into the healthcare? No, very slow. Why? There are a lot of regulatory people that are around, especially you need FDA approval majority of the time before you bring anything. Liability, who is responsible? If you use AI and something happens to the patient, privacy, very important, data quality integration, ethics is, who made that decision. So a lot of this, and we always say human brain is a human brain. Usually this kind of artificial intelligence do not have lack of creativity. So this came out just in March of this year along with the ACC meeting that artificial intelligence in cardiovascular care advances. So we will go over some of them, ECG, echocardiogram, MRI, and coronary angiography they're talking about, but it hasn't come about. But echocardiogram as well as CT and MRI can now be read after having trained these machines that they can read MRI of these people. So if you see here, where AI has really been used is in EKG detection and lot of wearables. The Apple Watch where you have the wearable EKG detection that uses AI, echocardiogram, CT, MR. Coronary angiography is very early stages. Lot of publications are there, but these are all retrospective data. There's not a prospective data to say, yes, it has to come into existence. So if you see here, in 2020 and 2022, lot of research has come out and everything is talking about AI. Before that, very rarely any publications, but now we are talking over 900 publications that has come out, and most of that is in United States, if you see there, and majority of that is in data, clinical decision making and prediction, those kind of things. So if you see here, around 600 FDA approved clinical applications are around which have been using AI, only 10% is in cardiology. So there's a lot of work that needs to be done before we can say, yes, we are moving on to AI. So American Heart Association, American College of Cardiology already have a lot of scientific statements saying that AI is the future. So how can we use it and where is it that we need to use it? So a lot of research is going to happen, but more important is still it is being tested. So we got to be part of this and make sure the future is going to happen using the AI. Now, a lot of publication is happening. So if you call ChatGPT and say, okay, so and so, this and that, please write a letter of recommendation, and you give certain criteria, a letter immediately comes in 1 minute. So when we are writing a manuscript, can we use AI? So what they're saying is that yes, you can use it, but you need to disclose. But AI cannot be an author, okay? So use it, augment your knowledge, but AI cannot be the author there. Why is Mount Sinai Health System using artificial intelligence currently? So there are two places where right now we are using. One is Viz.ai and AI Doc. So what are these things doing? Both are CT scans. So CT scan, echo and all that are easier in a sense. CT scan is way easier because it is a still image. So it will do the diagnosis, but what does it do? It will immediately send an alert. So a patient has aortic dissection, patient has a bleed, patient has a stroke. It sends an alert to the physician. The final decision is made by the physician, not by the AI, so it just helps the physician in making the diagnosis. And Mount Sinai has this bot where you can make appointments, refill medication, gives you location, direction. So in a very primitive manner, AI is currently being used in Mount Sinai. This was a publication that came out using EPIC. They did a predictive model to understand fall and malnutrition assess algorithm in this patient, saying that who will benefit from checking on them. So it's in a limited capacity. Adoption is happening. It's a very early stages. Now, where are we in the cath lab and in cardiology? AI clinical use cases. So the first and foremost was angio-FFR. This was a study. This again was a retrospective in the sense that what they did was they did the angiogram, they did several views, then they fed it to a machine, and afterwards they did the FFR, both on CT scan as well as the invasive, and found that there's a good correlation between the two. So we are never a believer of retrospective, we want prospective. So All Rise will be a prospective trial, about 1900 patients, which will start, and same, not STEMI, non-STEMI patients, we will be having non-invasive FFR and an invasive FFR, and there will be an outcome, okay? So we are to see by doing this way, is there any change in patient's outcome in these cases? Now, this is something we currently are using in the cath lab, where we can do imaging, means after you do an angiogram, you want to see exactly what's happening inside the artery, we can use a special catheter. Once we do it, immediately this machine has set algorithm, it will give you an answer that this is calcium, this is a lipid, this is where the blockage is. So it will help the doctor to make quick diagnosis. Same thing with the IVUS. IVUS is a different kind of imaging. And already you see that it gives you a calculation. You don't have to manually sit and calculate what is the percent diameter stenosis, the length of the lesion, and after doing the stent, that is the stent properly placed in the right place. All these are quickly done, which helps the physician to do the cases faster. So this was done from here, Mount Sinai, from our people saying that you can use EKG and detect RV dysfunction. So essentially what we are trying to say is, nowadays what happens? You do an EKG, then we do an echo, then you have to do sometimes MRI, sometimes you need CT scan. So they used AI data to say, based on the EKG signals, can we detect that this patient has RV dysfunction, LV dysfunction? They were able to do that. This is early detection of low EF based on EKG. Where will this be helpful? Patient comes to the ED, patient comes to doctor's office. Just based on the EKG, that you can say this patient has a low EF, you don't need to do an echocardiogram. These are all early stages, and there's a lot of work going on along that way. Now, I don't know if anything was discussed about this, that's CT-based FFR. So CT scan, right now, once upon a time, if there used to be that patient has coronary artery disease, what do you do next? Used to be a stress test. So that's out now. Patient usually go and get a CT scan. Now there's other thing that's added. Okay, you had a blockage. Is this blockage significant or not? You can do a test called fractional flow reserve, understanding the pressure gradient across the lesion, and then make a decision. Does this person need a stent or no? So that they used AI to make that decision, and that particular publication has come out, and this is the first one, CT-based FFR, made it to the guidelines. All our, the way we practice cardiology and interventional cardiology is all based on the guideline. For the first time, this CT FFR based on AI has made it to the guideline, but that too, it is 2A. There's level 1, level 2, level 3 evidence. This is 2A saying that yes, that can be used. A couple of the AI projects that we are doing here in Mount Sinai in our cath lab. And I think this was discussed, yellow trial. So yellow 2 was a randomized trial where we use rosuvastatin on stable lesion, not randomized, just rosuvastatin on stable patients, 8 to 12 weeks. And there we used AI to figure out the gene expression of the patients and who were better. Yellow 3, we already presented this data on evolocumab. So they're already on statin. Now we gave PCSK9 for 26 weeks. And here also what we are doing is using AI and predicting who are responders and non-responders to the evolocumab treatment in the yellow 3. So, a lot of this predictive model is future is going to be using AI. Now, I also said that there are so many other things that are being detected, which is CT scan as well as echocardiogram, where, AI is being used. Angiogram, it's very hard. It's a movie. When it's a movie, it's very hard for the computer. No, it's not, like I said, it's not as smart as human brain, but there are a few things it's very smart. When there is a moving object, it cannot make a decision, is this a significant disease or not a disease? So we are working on that. This was our initial publication from 2021. We didn't have a good correlation of angiogram. We did what is called as deep learning, we created an algorithm telling the machine, can you detect, is it a lesion or no? There was not a good correlation. Now, the machines, even the robots have become smarter. So now what we have done is you take training set. So this is the key. Whenever you are looking at, okay, this is the AI model, this is the predictive model, you need to see, did any person who is authority in that particular field has trained the model. The authority in the field has to train the model. Then that's the time you can say, yes, this is right and this is the right way that is done. So we trained the model. So you see that angioframe, we took the training set, more than 600 images, and there are various lesion detection. And right now, not only we can detect the lesion, we can also detect complex lesion, which is bifurcation, that is the branch and all that. These are complex lesion subset, and we are ready with something like that. So multimodality unsupervised, that was supervised, and then what we are also doing is taking more than 7,000 angiogram that we are here, we have then feed it to another model to see that can this model detect lesion. So this will be the first video-based angiographic AI analysis which is going on. Hopefully I'll be able to present the data next year. What is the outlook and what is the future goal for using AI in cath lab? So future goal is that we already want to detect what is a bifurcation lesion. We already have so many apps, and one of the apps that important one is the Bifurcate 3D, where we can say which way can we intervene the bifurcation lesion. So the model will detect the lesion, then we train the model. If you see this kind of a lesion, this is the way you have to do the intervention. So not only will it detect the lesion, it will then tell the physician for the best outcome, this is the way you need to take care of the lesion. Increasing difficulty is some of the lesions are very easy. Oh, there is calcium, there is a thrombus, but as we go further and further, that will be harder. So then not only do we have to train by angiogram, remember I showed you how you can do OCT and IVUS, we are going to incorporate imaging into that, and that way the model will be able to recognize what kind of a lesion. Is it calcium? Calcium means you have to do rotational atherectomy. If it is thrombus, you have to do another kind of thrombectomy. Then at the end, of course, you do the stent. Treatment will be totally different. So those kind of models can be done. We were the first one from yellow to also to predict based on what is called as the shear stress. Depending on the flow of the blood, you will understand how much stress is there on the vessel wall. So if you see there, at that time we created 3D model and predicted which patient can have further lesion, I would say, problems. So that will be another one we'll be incorporating in this kind of model to understand. Just switching gears quickly, I know Derek spoke about STEMI, but I want to tell you what will be the future of STEMI app when it comes to using AI. So we all know door in, door out should be 45 minutes if your transfer, and EKG should be less than 10 minutes. We know that. And we have 90 minutes for if the patient presents to the ER and 120 minutes for the transfer. So this was our hospital. I know Dr. Sharma probably showed you we are number one everywhere, but this one, close eyes, because we were doing poorly. And this is how 2018, 2019, myself, Parasuram was a fellow with me. We decided, let's think about something and create an app for that. It's not just us. This is across, okay, if you see 2010, what is happening in rest of the United States. You see that even there, the numbers are very poor. That door in, door out is almost 60 minutes, not 45 minutes, 60 minutes. And EMS to PCI time barely making it, to 80 minutes or so. This was presented in 2022 AHA transfer. 25,000 transfer patients across the United States. So if you see there, in only one quarter, okay, in one quarter, only 25% of the cases met the goal of 120 minutes. Okay, in United States, this day and age, we are not able to take care of these acute cases because of communication problem, system delays. So how can we get better? And this is what American Heart Association came up with, that you can, if the patient is if there is a patient at home, and if there is a way that you can make a decision rather than go to the ED, bring the patient directly to the cath lab, so you save another 25 to 40 minutes. So there are criteria. So based on that, you can, but we are still worried. You don't know. You're just depending on what the EMS person is telling you. So why don't we have a communication platform? And that is where we made this STEMI app. But it's not that easy to give the app to EMS yet. So we started using it from our ED to the cath lab. And if you see that American Heart Association thought about it in 2020, we thought about it in 2018. So we started first and then we placed in, we wanted it very earlier, but 2020, because of the pandemic, it was delayed. But right now we are using it across the system gradually and slowly. These are all the publications related to the STEMI. And since we started using it, door in, door out, which was about 68, had to be 45, became 52. And look at the transfer cases. only about 70% made the time in the past. Now 100% of the patients are having their PCI done in less than 120 minutes. Actually, the time is 91 minutes. So if you do your PCI on time, what happens? Your mortality improves. So how do we know that? This is the ACC NCDR data. In-hospital death for STEMI patients is compared to the entire ACC NCDR. Look at that. It is over 7 million, whatever it is, in hospital. Look at Mount Sinai. 2 for the entire country, we are 0.3. Okay, telling that yes, by this we are giving excellent care to our patients and the survival is better. So currently, what we have is an old kind of app. The future update will be AI trained EKG, conversational AI, just like your Siri, So the EMS has the app and he's talking, and that will automatically be transmitted to us, the interventional cardiologists, and then also there will be AI generated suggestion, chatbot, and all these things on this patient. This is the future, which is the vision, which is going to be that patient is having chest pain, and then what happens? There is a 12-lead EKG by the EMS. That 12-lead EKG gets uploaded to the cloud automatically, okay, and that the alert goes to the IC. So now the IC can do a video call, okay, to the patient and confirm that yes, this is a STEMI. The ambulance then will bring the patient directly to the cath lab. Now when that thing happens, the IC is already, the cath lab people already know we have room ready and equipment ready. So in a city like New York, where we are very busy, you need to have room ready because we are always busy doing cases all the time. So we are all fully prepared. So that's the future, and hopefully by 2025, we will have a wearable, okay, we will be wearable, either a ring or a watch, where a 12-lead EKG through AI interpretation will recognize STEMI, alert the EMS, and alert the interventional cardiologist. Somebody is having a STEMI, patient is on the way to you for the nearest. So just in conclusion and future direction, that for AI advances, what we need is participation from academic institution, regulatory agencies, and hospital administration is a must. It is again a team approach. It cannot be just one person. And like I told you, there's still a long way to go, but there are some changes that happen. So there are a lot of barriers to overcome because a lot of people are resistant. It's always a resistance to change. We definitely will do a better delivery of cardiovascular care if AI is being used. Just wanted to tell you, this is our staff. We had April 20th, Central Park, where 5K run for fun, and on June 21st, we are going to have our International Yoga Day, not 22nd, 21st is the summer solstice. Just to tell you, I'm not sure if anybody has mentioned, but this is the growing library of app. I want everyone, QR code, download all the apps. The app that we released for this symposium is a device aid, and every cath lab personnel should have this device aid with them, so that every cath lab devices are in there, which will include starting from access till closure. So every device that is out there has been excluded. And thank you for your attention.